Hi, and thank you for joining us at Duke School of Nursing for the Dean's Lecture Series featuring Dr. Peter Buerhaus today. I'm Katie Bowler-Young. I'm the Assistant Dean of Communications, Marketing, and Business Development at the school, and it's a pleasure to welcome you and also share a few logistical details to get us started. Today's presentation will be delivered both in English and in Spanish. If you are seeking Spanish interpretation, there is an icon, a globe icon in Zoom that you can click on to choose the Spanish channel. We're also providing auto closed captioning that you can also turn on. Now it's my pleasure to introduce Dean Vincent Guillermo Ramos, the 12th Dean of Duke School of Nursing. He's also an alumnus of the school and director of the Center for Latino, Adolescent, and Family Health. Dean Ramos has been a leader in reducing health inequities, and his research has been supported by the NIH, CDC, and other federal agencies and private foundations. Dean Ramos is an appointed member of the Presidential Advisory Council on HIV/AIDS and serves on the Latino Commission on AIDS Board of Directors as vice chair. He is also on the Power to Decide Board of Directors and the Ending the HIV Epidemic Working Group of the HIV Medicine Association as co-chair. It's a pleasure to welcome Dean Ramos.
Thank you so much, Katie, for that introduction. So thank you to all the members of the Duke University School of Nursing community, as well as our colleagues across campus and in the field of healthcare for joining us today. I am Vincent Guillermo Ramos, Dean of the School of Nursing and Vice Chancellor for Nursing Affairs at Duke University. I am so pleased that you have joined us for this third lecture in our Building Upon Excellence Dean's Lecture Series. The Dean's Lecture Series features speakers to connect our Doosan community, alumni, school partners, and friends with experts and educators on topics that address the role of nurses in addressing the social determinants of health, developing new models of nurse-led healthcare, growing and supporting a diverse and inclusive nursing workforce, and communicating the value and impact of nursing within the field of healthcare. The Dean's Lecture Series will continue in the fall semester, and we have a really exciting lineup of speakers. In the fall, we'll have Dr. Margarita Alegria from Harvard Medical School. She's a professor and chief of the Disparities Research Unit at Massachusetts General Hospital, and she will be with us to host our Hispanic Heritage Month. We also have in the fall a New York Times journalist, Lauren Hilgers, who recently wrote a New York Times Magazine story focused on the nursing workforce and our value. We have Dr. Regina Cunningham, CEO of the Hospital of the University of Pennsylvania. And we have Congresswoman Lauren Underwood, U.S. Representative from Illinois, Illinois' 14th Congressional District and registered nurse. It's really, really an exciting time at Doosan, and really excited that we have had such a wonderful group of speakers over the past couple of months, and looking forward into next year. It's now my pleasure to introduce a very, very important distinguished colleague, Dr. Peter Buerhaus. Dr. Buerhaus is professor of nursing and the director of the Center for Interdisciplinary Health Workforce Studies at the College of Nursing at Montana State University. In this role, he maintains an active research program involving studies on employment, education, and demographic trends in the healthcare workforce, as well as on measures of quantity, quality, and cost of hospital nursing care and healthcare provided by nurse practitioners. Before joining Montana State University in 2016, Dr. Buerhaus was a distinguished professor and senior associate dean for research at Vanderbilt University School of Nursing. His other prior appointments include positions at the Harvard School of Public Health and the University of Michigan. Dr. Buerhaus recently served as a member of the National Academy of Science, Engineering, and Medicine Committee on the Future of Nursing, 2020 to 2030. In 2010, Dr. Buerhaus was appointed chair of the National Healthcare Workforce Commission, which was created under the Affordable Care Act to advise Congress and the Administration on Health Workforce Policy. Dr. Buerhaus is a member of both the National Academies of Medicine and the American Academy of Nursing, and have served on a number of national level nursing and health focused advisory councils, committees, and boards, including at the National Institutes of Health. He has earned his bachelor's degree in nursing from Mankato State University, a master's degree in nursing health services administration from the University of Michigan, and a master's degree in community health nursing from Wayne State University, as well as a doctoral degree from Wayne State. He completed a Robert Wood Johnson Foundation postdoctoral faculty fellowship in healthcare finance at Johns Hopkins University. As a healthcare economist and nurse, Dr. Buerhaus's focus on the healthcare and nursing workforces throughout his career has given him a unique perspective on trends, challenges, and strategies affecting the profession. At this juncture, his wealth of expertise will be invaluable for us at Doosan as we continue to develop our strategy for training the next generation of nursing leaders. Please join me in welcoming our distinguished lecturer today to the Building on Excellence Dean's Lecture Series, Dr. Peter Buerhaus.
Hi, I'm just getting my screen up, and I just need to do it one more time, I think. There. Can you see my slides?
We can.
Yes.
Oh, good. Okay. Whew. All right. Well, thank you so much, Vincent, for that very kind introduction. I appreciate it. And I am really delighted to be with you. There are some places that you just feel like you want to give a little extra effort because of who they are. And Duke is one of those programs and leaders in the nation. So it means a lot to be in front of you, but it means a lot for you to be making bold changes and decisions going forward. It helps the rest of us. So I convinced the dean to give me a whole 60 minutes. I'll try to use that time wisely. We'll have some time afterwards for some conversation. I do want to say thank you to Jenna and Katie. They've been kind of holding my hand for a while, and I really appreciate that. So let me begin by just sort of saying, here's my big picture look at the world at the moment. We've just had this incredible impact with COVID. It's been disruptive, not just to healthcare and public health and nurses, but really to society and our economic and political fabric of the country. And it's not over with. It keeps delivering. And one of the things that sort of I think we might all agree on is that if there's one thing predictable about COVID, it's that it's unpredictable. And I feel at times we have lapsed into, well, how do you know what to do? We just have to wait and see what happens with COVID. And we can get caught up in that sort of thinking versus one that says, we're going to take charge of our future. We're going to plan that future. We're going to make that future better versus waiting to see what happens. And so I'm hoping that today that'll add to that spark of what I know exists at Duke, is to create that better future. And we're not out of the woods yet. We have lots of things going on with the variant and other issues that are happening. And there's a lot of distractions. And I just want to point out there we go, some of the distractions. And I don't mean this in a negative way, but when you talk with a lot of people, you'll hear some say the most important thing to do is burnout, to relieve burnout, to decrease overtime, the low staffing, all these things that you can see on the slide. And let me say those out loud because I do know that we're translating. So traveler nurses, mandatory patient to staffing, nurse staffing ratios, the undervaluation or underappreciation of nurses, the moral fatigue, the compassion fatigue, the resilience and trauma care. And we need to, by the way, separate nurses from their room charges. All of these are out there and they're strongly held, they're points of view, but they in themselves are actions that have importance, but we're missing an overall strategy. And so I want to sort of move us up to think about a strategy versus necessarily focusing in on specific actions. To me, what I think is important is to first assess where have we been and what are our strengths, and to acknowledge them and ask how can we leverage going forward based on our strengths today. So I'm going to talk about 5 strengths in particular. Then I think after that, we want to zero in on the pandemic and try to assess where we're at this point in times. And I'll share with you sort of a labor economic perspective on the economic impacts, but also I'll show you a worrisome slide that depicts some changes in 2021 that I think we need to pay serious attention to. After that, we'll move into how we might overcome the challenges facing our nursing workforce. And I've got sort of 3 bullet points of the immediate challenges, imperatives, and longer term challenges. This will all take about 55, 60 minutes, and then we'll have some conversation. So that's the layout of the day. I want to disclose the organizations who have been recent or past funders of this work. You can see them on the slide, and also some other relationships with boards and committee memberships, none of which in my mind biases my thoughts about what I'm going to talk about today. Also, just to quickly acknowledge my research teams. There are 4 teams, lots of different people. These are my teammates, and most of us have been together for many years, and I sort of rest on their shoulders, and I just wanted to quickly acknowledge them, too many to name individually. So let's begin with the strengths of the nursing workforce. Now, there's a lot of them. I've put them all on one slide so you can see them. And as you're looking at them, the image that I have is, I live out here in Montana, and when we get into late July and August, the smoke from the fire seasons, from both fires in Montana and West, starts coming in. By noon, you're having trouble seeing the mountains that are just right over there. And later in the afternoon, you're noticing sort of your lungs are getting a little irritated, your nose. And what happens is it just sort of closes you off. You're not aware of the mountains. You're not aware of the beauty. You're kind of brought into yourself and your immediate in world. And I think COVID has done that in many ways. We have lived today and hope that tomorrow would be better. And it's been a very focused time of our workforce. But I think it's important to let the winds blow in and get rid of that smoke and look at some of these important strengths. And I would also say, before we delve into them, I'm going to be talking about the 5 on the left, not the 6 through 10 on the right. I wish we had time, but we don't. But remember that these strengths occurred because there were leaders, faculty, policy, research, and healthcare delivery systems who saw challenges in their day, back in the 80s and 90s, and said, we need to grow it better. And they've done that, and we can rest on that. And I think we want to be looking at ourselves and saying, how can we make the next 10 years better and add to this group of positive strengths? So anyways, so let's get going. And the first strength that I would say is, we have an increasingly educated and increasingly diverse workforce. So for 10 years now, we've been graduating more RNs with a bachelor's degree than with an associate's degree. And that trend is continuing. Now, back 20 years ago in 2000, we would show these data where there's just 5,000, 6,000, 7,000 nurses each year graduating with a master's or higher degree. Today, it's 50,000. So we have really amped up the educational qualifications of the nursing workforce. And some of those education gains have also been experienced by people of color. There's a lot going on this slide, but if you look at the white RNs over here on the left, and then you see other groups to the right of that. And for example, Black African Americans. So almost 53% report having a bachelor's degree compared to 48% or 49% for whites. You see that happening across other groups as well. And if you look at graduate and degrees, masters and PhD and DNPs, you see in general the same sorts of trend. So we've made strong educational gains, and they have moved over and embraced as well people of color. This is, I think, a good strength that I don't know that is widely known, given the conversations of today. So, but it's important. This strength needs to continue as we move forward as well. About the workforce, this is some data that comes from the National the Future of Nursing report. You can see the different racial groups on the left. In the middle is their composition, their percentage in the nursing workforce compared to the overall percentage in the population. So Black African Americans, about 12% of the workforce are Black African Americans, compared to 13.4% in the overall population. These are data through 2018. Asians, you can see if anything, there might be an overrepresentation in the workforce. Hispanics, here's the big gap. Only 7.4% in nursing in 2018 compared to 18.5% in the population. Now, if you look at the data and you just sort of look in the few years just leading up to 2018, you start to see an upward slope in that curve. And what I'm trying to say is, I think we're making on the verge of making some significant progress there to start closing that gap. So I think if we were to come back in 5 years and look at that, we would have made a pretty big dent in closing that gap. So I'm optimistic, but that jumps out to me as sort of the big area for some national concern. Now, these are national data. And what I think is important is to look at our local communities and assess the composition there, and look at our workforce and our students, and make sure that we are aligning and matching the characteristics of our community with our students and our workforce, so that we can get greater racial accordance and ideally better health outcomes. So that's the one sort of look at the education, the diversity, and we have more men in nursing. It's been a slow growth, but we're up to about 12% of the workforce, which is roughly about 400,000 full-time nurses who are men in the workforce. So that's the first strength. The second strength I want to mention is the amazing to me how the public continues to trust nurses above all other professions or occupations. If you think back to the last 20 years, there's been an enormous amount of disruptions, ranging from political to social to technological, cultural, demographic. All of that has gone on, and then we have COVID. And yet nurses remain the most trusted. We've done some work on this area with our survey research team to understand, why is that? What's driving this? And there's many reasons, but the three that seem to be the strongest held views of the public is that the public looks at nurses and views nurses as keeping them safe and protecting them when they're in our healthcare institutions, and particularly in hospitals where things can be harmful, or the environment is very complex. You may be under anesthesia, not awake, and your trust is in nurses to keep you safe. It's also to assure quality of care, particularly among older Americans who, this is a worry for them, is to be admitted into a hospital where there are shortages. This means lower quality in their eyes, and that is concerning to them. So quality is the second. The third area is that the public looks at nurses and views them in a way of, I can trust nurses to give me good advice on very confidential personal health care issues, and that's important to me. So these are some important sort of underlying reasons for this. And I want to show you a slide that this is data that, or this is representing a national survey that was done by Harvard, the New York Times, and the Commonwealth Fund. This was a survey, a national survey done in the last part of the summer of 2019 and into the fall, just months before COVID. Now, at that time, we were into the presidential election season, and the number one issue among society was the high cost of healthcare. That trumped every other issue at that period of time. So this was a very in-depth survey, and I found this chart in the survey, and I thought you might be interested in this. This was, the question was, who do you have in terms of trust to improve the US healthcare system? Now, it didn't matter if at that time you were for Medicare for all, or you wanted to get rid of the ACA, or you wanted to keep the ACA and improve it. Didn't matter. People ranked nurses highest as having a great deal of trust in improving healthcare system. Now, as you look at these data, these are 30 percentage points higher than physicians, hospitals, labor unions. So this isn't a close comparison here. This is a big, big difference in trust. And then, of course, when you look at the yellow, you can see the folks and organizations that do not engender much public trust in nursing. So this was the situation prior to 2019. And of course, we've got the annual Gallup polls that come out that are done in December. I thought I would show you the question. It gets reported out as trust. I don't know why that happens. The actual question is rating about honesty and ethical standards. And so if you look at the data, and if we went all the way back for another 15 years, you would see that nurses are consistently in the mid 80s in terms of the percent who feels that they have the highest honesty and ethical standards, 20 percentage points above that of physicians. So again, this is not a close comparison. So the public has strong views about nursing. And I think these views end up into explaining the third strength of our profession is we have astonishing and persistent support for nurses. And we could have 3 slides like this, but just highlighting the Johnson & Johnson campaign for nursing's future that was enormously impactful. And we'll see a little bit of that in a few minutes. The new campaign that began later, and then the Robert Wood Johnson Foundation, numerous initiatives, and I can count close to 750 million, maybe even more, in spending by the foundation to support nurses over the past 20 years. The Jonas Family Foundation, numerous initiatives there, including supporting nurses for doctoral education. The Gordon and Betty Moore Foundation out on the West Coast, several $100 million to support nurses. The AARP, the largest interest group in nurses in the nation, strongly supporting of registered nurses and of APRNs. And over this period of time, somewhere around 35 states have developed workforce centers focused on nurses to gather data, collect information, report it out, form the policymaking environment in their states. And then more recently, from my own institution, we received a gift of $101 million. And that was specifically to grow up the nursing workforce at the APRN and undergraduate level, provide the knowledge base to work in rural areas. We're more than rural out here in Montana, we're frontier. So we have come to a point of realizing it's going to be on nurses to provide that rural health care. Our medical colleagues are just not able to do that. Recently, $150 million went to University of Pennsylvania, again, to support their nurse practitioner workforce in addressing rural and other underserved areas that address social determinants of healthcare and really try to resolve some of the health inequities. So society has given a lot to nursing, and more recently looking to nursing as where we want to invest if we want better healthcare in this country. It's an amazing strength. Fourth strength is we have improving projections of the future supply of nurses. Our last published work on this was in 2017. We used data through 2016 to forecast the future supply of nurses. And about 2.5 months ago, our team, now using even a little bit more data up through 2019, just before the pandemic, we did a new forecast, and what you can see is that we expect the workforce between 2020 and 2030 to grow by 1 million. And underneath that is we project about 640,000 baby boom RNs who we believe will retire out of the workforce over the next, well, 9 years now, 8 years. And this forecast says we're going to be replacing all of those 640,000 RNs numerically, and we'll grow the workforce another 1 million above that. This is a very, very positive view of the workforce using data right up through 2019. And we'll see this slide again here in a moment. The last strength I want to talk about is the growth of our advanced practice registered nurse workforce. There's a lot of data on this slide, and in part, it's a little hard to give you the right numbers for the APRN workforce. That's because so many have different, or have more than one role. They may be a nurse practitioner and a certified nurse midwife. So how do you exactly count that? So you can see some data on that, but there's a large number of nurse practitioners, and this growth has been particularly strong, or not nurse practitioners, APRNs, has been particularly strong over the past 10 years. Now, I want you to, did I miss something here? I just want to check. Nope. Okay. So this data shows the growth in nurse practitioner employment. About 240,000 today in total. We have better data on nurse practitioners, so that's why I'm showing you that. And that's a growth, a significant growth. Going back to 2010, it was under 100,000. Now, in just 10 years, we've gone from 90,000 to 241,000. Most, or the largest number of those nurse practitioners work in physicians' offices. You can see that in the yellow line. The gray line are hospitals, which employ around 93,000 nurses, and then another 38,000 nurse practitioners located in all kinds of different organizations, in communities, in manufacturing facilities, you name it, prisons, churches, etc. So the nurse practitioner workforce has grown tremendously, and it is in our institutions and in our communities where people live and work. It's a tremendous growth of employment. This was the slide I was looking for. I'm going to take a drink of water, and I'll let you take a look at some of the breakdown in where nurse practitioners are employed, both in the hospital-centered areas and in other settings. Now, if you look over on the right, that, I guess, salmon colored, the other settings, add another 20,000 NPs who are working in a long list of other organizations. This just shows some of these. So the field now is out in society. We're ubiquitous. Let's try that word again. Okay. And looking to the future, we published this study a few years ago in the New England Journal of Medicine, where we used our model, applied it to physicians and physicians associates, and you can see the significant growth. From 2016, we projected the workforce for NPs would more than double, going from 157,000 to almost 400,000. This is a very rapid rate. It far exceeds that of physicians or physicians associates. One of the things I think that was positive about this publication is, for some physicians, at least we heard from, it was helpful because it sort of gave the message that this is happening. There's not much we can do to slow this down. It's going to continue. How do we better take advantage of our nurse practitioners? That was the view of some. So I think it helped sort of move some folks away from the resistance category and to one of acceptance and saying, how's my future going to be shaped by having more NPs in? So that's, I think, a very important strength. So those are the 5 strengths I want to briefly mention that I've gone through. We have these others that we haven't had time to, but they're also important and significant. And what I just would suggest is that we, as we're thinking about our future, remember these strengths and others and build upon those, particularly if we are in a position where you at Duke need to reach out and say, we need some more support from corporations or from the public sector, government. You have a lot to show to deserve that strength and that support. And that's just one way of possibly using it. Now let's move on into the pandemic's impact. And I'm going to show you a few slides that come from a study that my econ team is doing. And we're looking at the economic impacts on the nurse workforce. And by that, I mean RNs, LPNs, and we've included nursing assistants in there as well. We're looking at their employment, their unemployment, their earnings, where they work, their characteristics by age and by race, all kinds of information. We collect this on a monthly basis, but then we collapse the months of a year into quarters. So each year has 4 quarters representing these data. And I'm not going to get into the details on these next 2 slides. I just wanted you to see what I'm ahead of myself by a slide. Let me slow down. And I want to focus in here on the impact of the pandemic on these 5 major healthcare delivery sectors where you see a lot of nurses employed. Now, please note, this is total employment. So these are nurses, but it's all other categories of healthcare workers in these particular sites. So it's more than just nurses. And up here on the left, you see February 2020, just before the pandemic, and all the way over to March of this year. So this is very up-to-date data. When the pandemic broke out, we had this immediate decrease in total employment. In offices of physicians, they dropped the most, down to 11%. The orange line are outpatient care facilities, the light blue are home health care, the yellow are nursing homes, and the gray are hospitals. Now, there was a sharp decrease and then a fairly quick beginning recovery and rebounding. But it was in October of 2020 when the outpatient care facilities, total employment in that area, finally reached pandemic levels and then exceeded the pandemic levels. So they've continued to remain above. It was a year later when the offices of physicians finally reached employment levels that were just before the pandemic and have now exceeded them. Hospitals in the gray, they've never really fully rebounded. They're staying at about a persistent 2.5% below total employment where they were just before the pandemic. Home health care in the blue, it's been persistently down about 4 to 5% through much of the pandemic, but more recently, in the beginning last fall and into this year, we've seen a beginning of a pickup, getting closer to where they were pre-pandemic. But the yellow line, these are our nursing homes, and it has been a continual month by month decline in the total numbers of people working in this setting. So we're down 16% in total employment in the nursing home sector. Now, here are the 3. I'm just going to quickly show you 2 slides. I'm not going to get into the detail. I just want you to see we look at things prior to the pandemic, and then we watch monthly data. We pull them into quarterly, and we watch to see what's this one. This is unemployment. So we're looking at unemployment for RNs, LPNs, and aides, and we're able to track this. This is one showing unemployment by racial characteristics. So these green are the white RNs and the red are people of color. And so we can track these trends as well. I've got another 30 slides of these, and we're not going to go there, that show all that data. And what I want to do is just sort of pull that together and suggest to you that from our look at these data, here's what I would summarize. Nationally, employment levels have decreased across the board for RNs, LPNs, and aides, the most for LPNs, nursing assistants, and the least for RNs. The decreases have been largest for those under 50. You'll see this in just a moment. Wages have gone up. Now, these are adjusted for inflation, and we know inflation has been up for the last 8 months. So this is important that there's this effort here to keep up with wages, and LPNs and assistants have enjoyed higher wage growth than that of RNs, and the highest earnings increases have occurred in hospitals. Now, with regard to unemployment, unemployment spiked across the board early in the pandemic, but for RNs and LPNs, it's pretty much back to where it was, the unemployment levels prior to the pandemic. So they're back to that level. But not for nursing assistants of color. They're the only group where unemployment, they still have higher unemployment rates than what they had prior to the pandemic. Here's the slide I want you to sort of look at closely. This is a drop in the RN workforce in 2021. This is about 115,000 drop. And if you look across the slide, you'll see there's never been a year where we've had such a significant drop. The vast majority of years, it's been an increase. This really is outstanding. And when we look at our prior forecasts and we compare to where we're at the end of 2021, we had projected a 4.5% increase from 2019 to 2021, and yet we're at minus 1.8%. This is important new information. We published this only late last week, and if you're interested, I can send you the paper on that. Now, note that the drop did not occur among RNs who are over 50. That's where we expected this to occur. Instead, it dropped in younger nurses, 35 to 49, and nurses even younger than 35. So this is something we need to pay attention to. We are trying to figure out if these changes are temporary or if they're permanent. These are possible reasons why some nurses were out of the market in 2021. We have a survey right now in the field, a national survey trying to assess from RN's point of view, are these temporary or permanent? We need to know that because part of our grant is to project the future supply of nurses going out to 2030, taking into account the impact of COVID. So we've got to figure out, was this a blip or is this something more permanent? So stay tuned on that. Now, we'll move into the last part of the talk, which is overcoming the challenges that are facing our workforce in addressing the post-pandemic health needs of society. I've categorized them in these three areas, and we've got a little bit of work to do. So hope you have your coffee or something to drink. Then we'll end up and we'll have some time for discussion. So I think the first thing that needs to be done is we've got to control the messaging about nurses and by nurses and hospitals. We need to assure a growing workforce for the future, entering into the profession, coming into our nursing education programs. In my view, we have had way too much negative imagery of the profession on television. And the social messaging, the tweeting, the reports are well, I use the word dreadful, but I'm not even sure that's strong enough. It's despicable oftentimes. And the negativity is quite alarming. And what I want to suggest, if we don't start counterbalancing this with positive portrayal of nurses, we risk decreasing entry into nursing education programs, which we need to grow the workforce. I am not suggesting we sweep things under the rug. I'm just saying we got to rebalance, because the view right now is pretty negative, and this could have ominous implications. And I want to make this point because this is the forecast. We've already seen a drop in our workforce in 2021. We need this forecast to get true, to become true, to grow nursing's capacity over the decade ahead. And you'll see that why that's so important in a few minutes as we get into longer term challenges. But let me take you back to the 1990s. Some of you may remember this. This was the decade of hospital restructuring or hospital reengineering, one of the two. And what was going on back then is we were trying new approaches to over the decades to control hospital costs and total national healthcare spending. Those two began to grow dramatically when Medicare and Medicaid were enacted in the mid-60s. And by the 70s, costs were exploding, and we attempted to use regulations to control costs and spending. Didn't work out so well. The 80s was prospective payment. We'll try that. Sort of worked, but not really. The 90s, the policy was, let's use market forces, economic competition, and we'll do that on the backs of HMOs. And we'll see if that can help decrease costs and spending and improve quality. Well, for a hospital, that meant to win contracts with HMOs, to have patients coming into your institution. You needed to quickly decrease your cost to be price competitive and win those contracts. Hospitals are a labor-intensive organization, and nurses are the largest component of labor and almost the most expensive hospital worker, if you will. So it's only natural that hospitals focused on decreasing their labor costs and nursing. Now, we were doing some studies on this back at that time, and what we reported out was that hospitals in the early part of the 90s and late 80s were growing their workforce by 2 to 3% each year, their RN workforce. In the 90s, that slowed down to about 1% per year. So it wasn't a drop, it was just a slowdown in the growth. But hospitals oftentimes reduce the support staff that enabled RNs to work. As a consequence, many RNs took to the streets and protested. And some of you may remember this. And these were very, very highly covered media events that occurred in cities across the nation, particularly in Washington, D.C. These grew so large and were so persistent that Congress got involved, funded a National Institute of Medicine study on the workforce in terms of quality in hospitals and nursing homes. But the unintended consequence was the public portrayal of nursing led to a decrease in interest in nursing, decreased enrollments, and decreased graduations. This is some data that we published years ago, and it shows the data from the UCLA annual freshman survey. They asked freshmen across the country about your career interests and so forth. And you see that the interest in nursing plummeted starting in around 1994 all the way through 2000. So that interest, a decreasing interest in nursing, showed up eventually in the number of nurses that were graduating from our programs. 1995, there were 97,000 RNs, or nurses sitting for their RN license, graduating that year. Just a few years later, that number had dropped to 67,000, a 30,000 decrease in the number of graduates. And if you go out to 2005, yes, things had begun to pick up, but we're still more than 10,000 graduating fewer, 10,000 fewer in 2005 compared to 1995. So these are important consequential you know, factors that we need to be very aware of, because not surprisingly, by 1998, we had the development of what turned out to be the last great national nursing shortage in the country. In 2001, the American Hospital Association reported that 126,000 open positions for RNs in hospitals around the country. Hospitals were closing inpatient units, reducing services, dropping hours for other things. There were reports of quality problems and safety problems that occurred. So this is sort of what's in my mind when I see this really negative imaging of nursing. Now, we were lucky back then because we had the Johnson & Johnson campaign that was launched in 2002. And this was a very explicit attempt to grow the workforce and to recast the image of nurses at that time. And some of you may remember the images of nursing in advertisements and commercials that played during the Olympics, the Super Bowl, everywhere. You couldn't miss these positive portrayals of nurses. They organized these celebrations, 36 celebrations in many American different cities where you dressed up, you got, well, out here in Montana, we say we gussy up. So you get on your best duds. And there were physicians and CEOs and nurses sitting together, having dinner and drinks and watching an amazing sort of evening focused on the importance of nurses, all together discussing that. Every high school counselor in the country received a hard copy brochure extolling the benefits of nursing. And so these are just some highlights of what occurred with that campaign. Here's what I'd like you to see. The campaign was begun in 2002. Now, these were the drops that I just mentioned and how concerning these were. And look at what happened soon after the campaign reversed the imaging of our profession. And we've had these growth all the way up through currently today. So an amazing opportunity for this private industry or private organization to change the course of nursing, but we may not have that in the current situation. So we have to, I think, really start controlling our messaging about nurses and about hospitals, and really put a more balanced image. And that means I have to do that, you have to do that, our professional associations, our media, social media, our unions. I don't do any interviews with the media unless I can talk about this issue, because it's so important. We've got to grow this workforce going forward. Now, second challenge is I think we need a major reset in our relationships. And these involve hospitals and nurses, nursing students, the public, and then our leadership and our education programs. And let me just come back and just make a couple comments. I think at the right time in our organizations, when we can feel like our feet are on the ground, we can start to look forward and not so, dominated by our issues with COVID. Hospital leaders, not just nurse executives, but leadership, needs, I think, time to discuss COVID with our nursing staff, air it all out. What were the positives that we did right? What were those good decisions we made? What did we learn about ourselves individually, clinically? How did we grow as nurses? How did we grow as leaders? What were the good things about our culture and our organization that we want to now grow and build on moving forward? At the same time, where did we screw up? What did we do that didn't turn out well? What did we learn about ourselves that wasn't so happy? What decisions did we make that didn't work out? And if we have to sort of say, look, I understand now why you did what you did. And if we even have to forgive each other, that's okay. We need to sort of bind up our relationships and point forward, knowing where we want to go. I think this involves nursing students. They were in and out of our organizations, left and right, up and down, rolling around. It was crazy. And they went through a lot. But do we know how they were impacted? What positive things did they see among staff that they want to emulate? What was it that excited them about being in the organization? We need to understand that, build on that, and re-invite them back into the organization as they finish their education. Let them know how important they are and how they will be part of a new future. I think also with our public and our community, and I don't mean this in a self-congratulatory way, but I think it's important for the public to hear from our organizations what we went through in COVID, the good, the difficulties. How many people were saved that are alive today because of nurses and others, but to showcase how many vaccinations were administered, how many tests, how many other things were occurred that were there to keep the public safe and protected and to ensure quality of care. I think it's a good message to reconnect with our community, despite all the politics and so forth. This is important for the public to know this about that profession that they trust and admire the most. And then I think our CNOs and our deans and also the leadership underneath the CNOs and the nursing faculty. This is very important, I think, for us to take time to reset those relationships. And what I want to suggest is that we really become joined at the hip. This is a whole new normal of a relationship. And in the past, we've had nice gatherings and conversations, and maybe some occasional get-togethers. What I'm suggesting is a very focused strategic relationship that is based on the nursing CNO understanding exactly what's on the dean's important list, what needs to happen for the dean, what needs to happen for the faculty, and vice versa. We in nursing education need to know what's going on in that organization, what's most important, how can we support that organization to achieve those. We've got to understand where each other are at so that our orbits are increasingly together and aligned and not just spinning out in different directions. So I feel that this is an important opportunity to grow that relationship and think of it in a strategic way. And I want to maybe go out a little bit on the end of the tree branch here and suggest too that in these relationships, we need to reset our economic relationships. I don't think it is realistic for nurses to expect huge increases in earnings going forward. We're going to have to sort of adjust back to something. And I would like to suggest that this is an opportunity for us to embrace value-based payment. Now, value-based payment is new systems that have been trying to get their feet on the ground and grow up over the past decade and sort of ran into the COVID and things slowed down. But these enjoy political support by Republicans, by Democrats in the House, and by previous administrations, including President Obama, Trump, and Biden. Everyone's aligned on that because the focus here on outcomes, value-based payment is let's produce the best outcomes and keeping our costs as low as possible. And we will pay organizations, we being Medicare and others, we will pay organizations and clinicians more if they produce higher levels of outcome and keep their costs low. We'll pay you less if you don't do that, if you produce mediocre or average or low outcomes and your costs are high. That's the system where we're at. We're making the transition, it's occurring. And what I want to suggest is that as we think about this new economic relationship that we need to find with our employers, is we embrace value-informed nursing practice. practice, where nurses focus on improving outcomes and reducing our costs. We're good at the outcomes. This is what we're really good at, and this is what you're good at in teaching the clinical aspects. We're not so good at the cost part. But I want you to just at least maybe think about how the incentives are now aligning, where nurses will be incentivized to improve patient care, as will hospitals, by improving outcomes and lowering costs. You nurses are now contributing to the economic stability of the organization, because the better the outcomes and the lower the cost, the more dollars that organization will receive. So now nurses are becoming empowered. They're not so much the high labor costs, but in fact, they are part of helping the organization increase its revenues. That's important, because those dollars can be invested to improve patient outcomes and patient care services, and give back to nursing rewards for doing that. So this is, I think, a new alignment we need to take advantage of. Now, I don't look to nursing faculty, and I'm one of them. So I'm just looking at myself, and I'm also looking at a big snowstorm that just came in out of nowhere. So I might be a little distracted, but at any rate, the faculty, you're good at outcomes, but the cost part, we didn't grow up this way. We grew up in a fee-for-service, cost-based system where we didn't have to really pay any attention to it. Now things are different. And I think organizations, healthcare delivery organizations, need to reach out to our faculty and involve them in strategies and opportunities and meetings and in-services or whatever, to say, these are the outcomes we're worried about, and here's what the costs are that we need to get out of the system. Use our innovation or our minds to look at the costs. I think we can solve these, but we don't know how to do it. We don't have the data. We don't know necessarily how the costs are calculated and identified. That all has to change. We've got to get much smarter. And I think a way of maybe doing this is, excuse me, we showed the world that nurses are extremely good at quality improvement. We lead a lot of those initiatives. Let's now adopt the quality improvement methods to explicate and grow up a value-informed nursing practice improvement, so that we, in a short period of time, our first care plan that you write as a nurse, it has all the outcomes for clinical, but it also says, here's ideas or experiments that we could use to figure out how we could lower the cost of patients like that. That's the new kind of mental framework that I think we need to change going forward to help redress the economic relationship. Now, last, and then I'll finish up, I'm going to try to move this along pretty quick. We've got some longer term challenges. Now, normally I would stop here and not get into this, because these are weighty challenges, but knowing you guys at Duke, you can handle it. And I just think we need to get it all out there to sort of really see the big picture. But we've got some supply side issues and we've got some demand side issues. I mentioned before, we have the retirement of the baby boom generation of nurses. And we estimate that about 70,000 baby boom RNs will retire each year over the next decade, or this decade. This is a loss of clinical organizational leadership, the mentorship, the ability to just figure it out and get things done. And while I said we have a lot of RNs projected into the workforce, that's not going to be a perfect substitution or replacement. We'll have to really work hard at finding ways over the next several years, and we've talked about this, but we really didn't do a good job about this, of imparting knowledge of our older workforce, to impart their wisdom and knowledge into the younger workforce earlier in their careers. We really need to do that significantly. This is a data that we published a few years ago, trying to make this point about the loss of millions of years of nursing experience from our workforce. And so we're projecting 2 million years of lost nursing experience every year this decade. But it won't necessarily affect hospitals the most. Most of this is going to be a retirement. It's going to be more so in nursing homes, rehab, home health, occupation. It will occur among our university School of Nursing leadership and faculty, and the leadership in hospitals. Those are the spots that this retirement is most likely to address. So we need to be thinking about preparing nurses in these areas to replace the baby boomers. Second supply issues, we've got the issue of leveraging this growing advanced practice workforce, and particularly nurse practitioners. You saw the slides that I showed in the past. We're producing these individuals, and yet we're not fully taking advantage of them through laws, organization constrictions. They're important. And this is a study that we did a few years ago at the dawning of the ACA. We wanted to see, well, where are all the people who are newly eligible for new benefits from the managed care or the Medicaid expansions in the country? Where's the workforce? Are they co-located? And ultimately, this is a slide that comes from that paper. We found that the population who lives in restricted states, only 34% had good geographic access to primary care. But states that were full practice states had double that in terms of their access. So access matters, and you can see how just on this slide. I also want to suggest that let's get rid of these damn maps. I am so sick and tired of making these things, and I'm not doing it anymore. It's just irritating that this is something that we reflect and we show when we talk about our practitioner workforce. This just makes no sense. We've got to find ways to reduce these barriers. And I want to show something that's close to home for you folks in North Carolina. This is a study we published a little while ago. We were looking at where do the dual eligibles reside in this country, where there's most dense. So the dual eligibles, they're Medicare, they receive Medicare and Medicaid. They're relatively small proportions of both the Medicaid population and the Medicare population, but they account for a third of the costs. So Medicare is over $800 billion, so is Medicaid. And so these people, very, very poor, are concentrated heavily in rural areas, and they're shown in the red dots. In the same areas are federal designation of physician shortages. And you see this clustering right in your neighborhood. Oh, look at this. These are the restricted states. Now, again, I didn't update Florida and California and so forth. But this is where we have these restrictions. And we need North Carolina to break through, get rid of these restrictions, and show the rest of the Southeast what can be done. Because in these same areas that are shown in red, if I had time, I would show you other slides. This is where you see many NPs actually in providing care for these dual eligible populations. So it's important. We need to get on with this. There are restrictions that we're familiar with. I think we may need to develop new partnerships that use APRNs differently. Maybe they're based on communities that are concerned with equity or diversity. Let's partner up with them. But how do we use this workforce more wisely? And by the way, we've had this big experiment of, I think about a dozen states said, we'll get rid of these restrictions on nurse practitioners as part of the emergency response to COVID. And I would like to see the data that shows, oh, by the way, when we did that and we gave full practice to these nurse practitioners, how many people died? How bad was the quality of care? What were the negative outcomes? There aren't any. So we should use that as we talk to our policymakers to say, we already have another living experiment. We don't need more data, we need action. And I feel strongly that we really need to come to terms with this and get this issue out of our lives. Finally, demand issues. We have a lot of growing demand for healthcare, and it runs into not enough numbers of nurses and APRNs who are trained in the right specialties or located where they can best meet these growing demands. This is some data. There's a lot here, but basically we have a strong growth in our population who are older, baby boomers aging into Medicare years, the mental and behavioral health issues that were already seen as crises before COVID now have worsened. The inadequate access to primary care has gotten worse over the decade, not better. And the high maternal mortality rates. When you look at our supply of both nurses and APRNs, we're woefully underpowered. And I think to me, I feel we've got in nursing education and our leadership, we've got to come to terms with this. Are we producing the workforce that will respond to these great societal demands for healthcare? Or are we producing what we want to produce? And I don't know that we have to give up anything, but what's the balance? Can we provide more primary care, geriatric, behavioral mental health? How do we really meaningfully respond to this? Because it's not going to happen by the physician community or others. There's just not enough there. There are enough numbers of nurses to make material differences. I really feel that given the amount of money that is coming into the workforce, we need to hold nursing education programs and all other education programs accountable for, are you producing the workforce that is needed by society? And if you're not, I think we need to look elsewhere to provide those federal funds or state funds to other institutions that would do that. I don't know how else we're going to sort of, get our minds around this unless we attach some economic costs and consequences to that. If we're going to do this, if we're going to close these gaps, we've got some resources, and this is the Future of Nursing report. And I think it would be wise to deal with these gaps by incorporating the learnings, the recommendations, the ideas that are in the report. It makes a lot of sense. So last slide. We've got a lot of strengths that are back. We need to leverage them. We've got the pandemic still affecting our workforce and now providing some uncertainty in 2021 with those decreases, which means we've really got to control the messaging about nurses and about hospitals. We've got to embrace our relationships, reset them, and move in a value-based payment model, in my view. We've got to anticipate this retirement, do a better job of preparing for that, leverage this growth of nurse practitioners and APRNs, and really close these gaps between societal demand and what we in nursing are producing. With that, I think I will say thank you. And I think we've got a good 15, 20 minutes. So there we are. I'm done. And shall I stop sharing the screen?
That would be excellent if you want to
Okay, good.
stop the screen share, and we'll
All right,
bring
there
you
we
in
go.
for a spotlight. Thank you, Dr.
Okay.
Buerhaus. Peter, that was a fabulous presentation, and I'm struck, like one of a faculty here, Ann Derwin, who also mentioned that we really appreciate your call to action around North Carolina being able to break through and take that lead in the South to provide access to care for vulnerable populations. So thank you. I also was really struck by your call to action around the need for positive imagery in addressing the workforce deficit. And I would love to ask more questions about that or share other comments, but I want to first turn to a question that we have received from Dr. Ernest Grant, who is the president of the American Nurses Association. And I'm just going to read his question verbatim. I have a question regarding your data on Black and other minority nurses achieving a BSN. I've seen data that reflects their primary degree is the associates and that they later acquire their BSN via online programs or going back to in-person school? Does your data reflect the growing minority BSN population as their primary degree or secondary degree?
That's a great question. And we don't have the ability in the data that we were looking at to determine that. So I think that's an important piece of information, which can kind of sharpen the view of educational advancement among African Americans. So Ernest, a great question. And I hope we can get that data. And I just, while I have you, I'm just a little worried about our ability to measure our progress, given the sort of the survey response rates and the sort of the problems that we experience with the national sample of registered nurses. So I'm hoping that you can kind of keep pushing this, because this is important. We got to get this right, and we got to get good, accurate measurements. And so thanks for the question.
Thanks, Peter. And I do want to mention people are adding questions to the Q&A, and so I will continue to return to the Q&A to frame questions to you. The next question that I have, I'm actually going to blend a question from the audience with my own questions too, that have to do with your challenge to us to introduce more positive imagery about nursing, so that we can address the workforce deficit and both stabilize the workforce and grow the workforce too. Right now, especially as the pandemic has progressed as it has, there have been numerous stories in the news about all of the challenges that nurses are facing in terms of staffing, PPE concerns, other more complicated circumstances around healthcare and legal issues. And also at the same time, a shift from nurses to working in other sectors and in other segments of healthcare. Do you have some concrete suggestions for us around the positive imagery? And can you also tell us more about how you think schools can play a role in increasing the positive imagery?
Well, I think that it's a great question, and I'll do the best I can. It's something, though, I think that needs to come out of a lot of discussion with our employers. And I think that right now the employer sector has had quite a few shocks, not just the COVID experience of a mass sudden surge of very critically ill patients, lacking then in initially supplies, and lacking in enough nurses who could actually address them. So they went to the marketplace of traveler nurses, and experienced more so in the second year, in 2021, the shock of rising payments that were really astounding. And I feel that this was a shock. It was an important opportunity for nursing now to say, we've got to do something different and better, or in the future, you could go through that again. And I don't think many organizations want to go through that. I think that was way too costly. It would be much less costly if they get into the relationships with nurses and figure out what that mutually supportive future is, which I think gets at sort of your question. We can't have a workforce that is so negative. We have to lift up and say, I've met nurses who this was their first year in their clinical world. Talk about a baptism of fire, but they come out and some have said, my gosh, I am where I'm at clinically knowledge, where I thought I'd be in 3 or 4 years. I'm there now. I am so much more confident. I have seen leadership. I have seen positives. I think those are the things that we need to lift up and recognize we're part of what we did, and to realize that we're in it together. If we don't have enrollment and we don't grow that workforce, we're all in a big bind. Also, as individuals who may need healthcare. So I think we just have to come to terms with and have a much more honest and meaningful discussion about where we want to go in the future, what changes are going to be necessary. And just to go even a little further, Katie, it could be that there are some nurses who are just so burned out, and maybe a different spot in healthcare is better for them than back in the hospital, or not. We need to have as many positive, forward-thinking, constructive people in the workforce as we can, and really identify and reward the performers and not so much the other. So we have to sort of take a look at ourselves and make sure we're educating those positive people and own up to that. But at the same time, get our organizations to take what's happened much more seriously and figure out what to do in the future. And part of that is the imaging of nursing.
It's interesting that you, I think, are calling us to have more of a conversation about this. We also have a comment from one of our guests who talks about the role of public perception of nursing, and perception around inpatient nursing versus outpatient home care, preventative health, community health. Do you think that there are earlier touch points that we have in the lives of the public where we can help to educate the public around all aspects of nursing?
Wow, what a great question. And I mean that because I think we have this image of the nursing workforce. It's all in hospitals. It's all dealing with COVID. If you add up the numbers, and don't quote me, but my guess is it's involving, in terms of intensive care, critical care units, and COVID units, roughly 350,000 nurses. And again, I could be off, but we have more than 3 million nurses, and they're working in, 40% are working in non-inpatient care units. We have a very big reach of our workforce. Not all have had the same experiences as our colleagues in the inpatient settings. So I think the person who's asking the question is really right on. Maybe we need to think about the various places where nurses are working and tell those stories, and not just the inpatient side as well. And again, I hope people will recognize, I'm not saying sweep it all under the floor. No, but we can't just, or under the rug. We got to pull the rug back and sweep around a little bit here and clean it up as much as we can. But for the good of all of us, we've got to watch that image for the reasons I showed, which I think are pretty revealing.
Thank you. I'm going to shift gears a little bit and ask about the role of nurses and their influence on policy. I'm reading a question from a colleague here at Doosan. I appreciated your data regarding the consistent favorable ratings on nurses on public trust. During the IOM Future of Nursing Report 2010, we commissioned a study by the Robert Wood Johnson Foundation that demonstrated that although nurses are ranked highest on trust, they're ranked lowest even after patients on influence on policy. How has the perception of the public on nurses' influence on policy shifted in the past 10 years? And what are your thoughts about how we can continue to shift that perception on the role of nurses influencing policy?
Have to consider that. I think I have a couple of thoughts. That one is, ever since I've been in this as a nurse and in the profession, I've heard one consistent message: we don't have enough nurses sitting at the policy table. And I think, in 20 years, we're still going to say that. I would disagree. I think we've had many examples of nurses leading Medicaid programs. We've had 2 nurses who have led the CMS, one when it was called CMS, and one when it was called the Healthcare Financing Administration, when we rolled out the prospective payment system. Carolyn Davis was a nurse that ran CMS. We've had people like Mary Wakefield, who at one point ran HRSA, also at high level in HHS. We've had leaders in Congress. Not to say that we have enough. We've had the Action by RWJ to get more nurses on boards. These are important growth of our profession. And I don't think that it is also bad or negative. I think what's really important is what you do when you are in those professions. Can you be a team player? Do you have the data to influence policy? And that's where I think our programs can be important, particularly in the D&P programs, of the policy influence and how do you work with members of the public or the private sector? Are we preparing that good leadership? Because I think people will want more nurses' involvement given the consequences of the pandemic and what we're preparing for in the future. So we just want to really make sure we're providing that strong group of people in leadership. And while I've got it, I'm just going to rant a little bit. That southeast corner, wouldn't it be great if, I don't know, I'm just thinking of all the major schools of nursing just saying, look, we're going to shut down for the day or a strike or something. We've got to get these restrictions removed from on nurse practitioners and others. Something that pulls us together in a policy world that's aimed at private and public sector. There's a lot of people supporting it. There are just certain groups that are not. And it's time to maybe confront that in a more visceral and visible way. I think the public would be pretty supportive of something like that. So I'll leave it at there, Katie.
Great.
Rescue
Thank
me.
you.
Rescue me. Give me a softie.
Okay. So I'm going to go back to an earlier part of your presentation when you were talking about employment, unemployment, and the closing of the gap around demographics of the population at large and demographics of the workforce. And one of our colleagues at the school asks, what are your thoughts on why nurses of color are the highest unemployed when the call is for a more diverse workforce that reflects the population?
So in their data, and I just showed you two quick slides, more for illustrative purposes than really counting for that. We've seen, let's see now, got to get my mind thinking here. At times we've seen people of color have had slightly higher unemployment rates than do whites. And then in the next quarter, it drops. There hasn't been a major consistent pattern among RNs. There was some early evidence that there was, but that seems to be back in line. It's the nursing aides that of color who are the most affected early on and all the way through the pandemic and all the way through today. So I don't know that our focus in nursing has been among aides as much as it has been among registered nurses, and sort of the focus there. Others are concerned about individuals in lower income categories. What's happened with nurse aides, I believe, has happened in other industries as well. Lower occupations being hit, lower education and skill been hit hardest in terms of the COVID's impact. So I'd have to go back and look at the data to be a little bit more precise on that, but that's my general understanding of what we found.
Thanks, Peter. And we have time just for one more question. And so I'm going to ask a question that has come in, but I'm going to reshape it just a little bit or add to it. The question is to see if you can comment on the magnet program and its value in nurse retention. But I'm going to add to that. We've talked a lot about building the workforce. What are some of the steps that you recommend around retention?
On the magnet, I have done some work, some studies years ago on that and found generally very positive results on retention, satisfaction, the things that magnet are good at. I don't know where magnet is right now in emphasizing sort of like the cost reduction responsibilities of nurses. And so that's the first part. And what was that second part, Katie, again?
What other recommendations might you have around retention?
So Retention has been an elusive one for me in the sense that I look at retention as both positive and negative. Some people are not the right match for an organization, or it's just not right. And so it's better that they leave and find a different organization. Nurses, because a large percentage, the largest percentage are women, and many are married and have spouses and partners, oftentimes leave because of a change in job opportunities for their partners or married. So it's hard for me to know when we see these numbers of retention and turnover, what's really happening in there. But I do think that there is a significant portion that are leaving because they're just not right in this organization. And I think there's an opportunity to understand why by organizations. Why are we losing some of those people? Because we may not want to lose them. So figure it out. Where's the problem, in a sense? Is it shared? Is it with the organization? And then try to solve that. Because if it's just a few people, it could be representing others as well. And we know that in the broader economy, some organizations just really do well with their employees, others don't. And hospitals need to really kind of get to that. And lastly, Katie, I'm encouraged because back in that time when we had the big national shortage, 2001-ish and 2, the Joint Commission, the AHA, they got on board. They had documents and meetings and a very sharp focus on doing it better in healthcare. And I think we need that leadership. They need to step forward along with Ernest and others in our nursing workforce, pulling together at a big level of solving these problems, doing the image, but getting down and really checking our values. What do we really want in our healthcare system? How can nurses be part of that solution?
Thank you, Peter. I want to thank everyone for joining us today. This has been a lively discussion with a lot of calls to action for next steps, practical steps that we all could be taking. Please continue to join us for Dean's Lecture Series events coming this fall. And once again, just a hearty thanks to Dr. Peter Buerhaus. And
thank you, Katie.
Thank you for joining us.
Appreciate it. Good luck to everyone. All my best wishes.
Thank you.
Thank you.